Gender differences in STEMI have been reported in the past. It's been very hard to have discussions on the topic. We have a very interesting paper in JACC Interventions, the September 2014 issue, Sex Differences and Response to PCI and Acute Myocardial Infarction. We're talking about the Octavia Study. And I'm with Giulio Guagliumi, who is from the hospital of the Pope, Giovanni, right?
Correct.
And we're talking from Bergamo,
Bergamo.
Italy.
Bergamo, Italy.
Excellent. And this has been a difficult topic to discuss. I mean, there's been such controversy about the sex differences. What did you set out to do with Octavia?
So I think that is a very important topic because there is an increasing numbers of ladies coming to the hospital searching for care with acute myocardial infarction. And all the data we have, they are very focused and mainly drive with men. And that is an issue because when you are running big studies and you don't have enough numbers of ladies coming, you cannot know the differences. Then in addition, we have three major factors. The first one is that the lady normally are coming searching for care of acute myocardial infarction 10 years later compared to the men. So they are older. The second one that because they are older, when they are coming with a lot of comorbidities, means much more risk factor. And the third one is they are different even in terms of vessel size. They are smaller, and that is not only for the coronary artery, but even for the periphery. So Octavia was one of the advanced study using radial approach in more than 50% of the patients. And so we learned a lot. When we decided to do this study, it was because we didn't have this data and because the data were unbalanced, confronting young men to the older lady. For this reason, we decided to have an age-match control study in a prospective way, multi-center study, having 14 Italian centers working together with multimodalities. To found the results, we use, as I was saying, multimodalities. What does it mean? Multimodality means that we were very precise in watching inside the coronary artery with very high resolution technology during the acute phase of MI, like OCT, optical coherence tomography, after thrombus aspiration if the patient needed. And the second is that it was not a pure imaging study because we combine blood samples to have a look to the different biomarkers, and we carefully assess with histopathology and immunohistochemistry the thrombus characteristic. So we have information about the type of the plaque, the content of the blood, and the content of the thrombus. And after having identified the culprit mechanisms in both sexes, we stented with one of the current advanced generation of the stent, and we watch with the same technology to the immediate response of the stent in men versus balanced women of the same age group, and then we send back home the patients with optimal medical therapy, and we collect back at 9 months for assessing the second endpoint, that was the healing process in the lady compared to the man. Coverage of the stents, evidence of any type of malapposition. So the two primary endpoints were one, the type of culprit plaque supporting the acute myocardial infarction, and the second one was the response to the current generation of the DS.
So what you find is something that will inform, I think,
absolutely,
clinical experience.
Absolutely. The first point is when there is some thrombus inside and we are trying to remove a thrombus, we have to figure out that even when we judge a perfect result from angiography, there is still a significant thrombus there. So in 1/3 of the patients, the culprit plaque was not possible to be analyzed due to the excessive amount of thrombus. For the remaining patients, we show that the type of the culprit plaque were absolutely similar between men and women. So the vast majority of the patients are coming independently by the sex with a rupture plaque, But erosion, that means one plaque that does not have a cavity, didn't went in contact with the blood, erosion is covering about 25% of the patients. That was the first point. So no difference in culprit plaque type, no difference in thrombus, no significant difference in blood. So same type of atherothrombotic mechanism in both sexes. The second point was to watch to the 9 months follow-up to see if ladies they are smaller with a different vessel can respond in the same way to the stent implantation of the current generation. And the answer is yes. Independently by the fact that they have a smaller vessel, they, for the vast majority, didn't have any type of protection from the estrogens because they were after the menopause. We saw that the healing process was the same. Same high rate of coverage and same very low rate of malposition. What else? There are two very important messages. In Octavia, we enroll patients within 6 hours of symptom. We say that we wanted to show in the golden hours what is going on in male and female. And so normally we are supposing that within 6 hours you are coming with a fresh thrombus. While that is not the case. 1/3 of the patient coming even within 6 hours have a clear sign of organization of the thrombus. It means that the symptoms started well before the final events. And this is one very important point. The second is that we had the confirmation that the ladies are coming later. Even within 6 hours, they try to wait too much to recognize the symptoms of acute myocardial infarction.
That's interesting. Sometimes you think the men are the ones who will say, no, I don't need to go. They're being big and macho. But in point of fact, it's women who are a little more likely to not get to the hospital in time.
Correct. And I think that this is an important point because women, until the menopause time, they are very protected by estrogen. But then, immediately after, the estrogen level is dramatically going down to 1/10 of before, and they are immediately exposed to the risk factor. And when they are exposed and not anymore protected, they have the same type of mechanisms that we have in men.
So anything else that we can take away from this? Because this is something that the FDA has been asking in the United States now, that we really do more analysis of women-specific data. Anything else we learned from Octavia?
I think that Octavia is it's a very sophisticated study by using multimodalities, but is not a huge trial. One of the messages is in the future, we needed to have much more evidence of any type of therapeutic intervention in ladies. Means that you cannot be so unbalanced like having 85% of the patient enroll male and leaving very few ladies enrolled. So we need not only dedicated study, but we needed to have much more balanced data between men and women, match for age, because that is the problem.
How about the femoral outcome?
Well, we didn't have any substantial difference, but you have to figure out that we are talking about 140 patients. We are doing the more and more radial. Exactly. So even in Octavia that started 3 years ago, we had more than 50% of the patients done by a radial approach at a time when it was not so popular like today. For the vast majority, with quite few exceptions, we are doing a radial approach. If there is the need, we are just going to femoral without any problems.
Terrific. Well, the paper is in JACC Interventions, and I really would encourage you to go take a look at it because there is some real definite information there on some of the differences between the sexes in terms of STEMI, and that is in JACC Interventions, and I am Rick McGuire, who is the executive editor of CardioSource World.